this only is spread through close contact through bodily fluids. And so it's not spread through respiratory spread at all. And so you can sit on a bus or a plane next to someone who has Ebola, and you're not going to get infected with Ebola. And the other really, really important thing about thinking about Ebola and spread of Ebola is that unlike other things that we think about, there's no pre-symptomatic spread. And so until you actually have symptoms, so fever, you are not capable of spreading the Ebola virus.
Ebola has a way of cutting through the noise of the news cycle. Its name alone can shift conversations in exam rooms and on living room couches. But what's circulating in headlines is not always what's circulating in real life. For pediatricians, that gap matters. In this episode, we break down what's actually happening right now with Ebola, what is known about current risk, and how clinicians can respond when families arrive with urgent questions. This is Charting Pediatrics. To guide us through the science, we are joined by Dr. Sam Dominguez. He is the medical director of the Clinical Microbiology Laboratory, as well as the associate medical director of infection control and prevention at Children's Hospital, Colorado. He is a professor at the University of Colorado School of Medicine. Sam, welcome to the podcast.
Great. Thank you for having me here.
So let's start with the current outbreak in the eastern region of the Democratic Republic of Congo. What's going on?
Yeah, so that's a great question. There's still lots for us to learn, I think, because we just got information about this over the past few weeks. But what we do know is that there's an outbreak that's occurring in sort of the northeastern province of the DRC, which importantly borders South Sudan and Uganda. And so there's concern about spillover into those countries that we can talk about a little bit later. But I think the key issue right now is that this outbreak went undetected for a little while, and there's several reasons for why that went undetected, primarily because it's a strain of Ebola virus that we don't look for as much, and it's the Bunda-Buja virus strain, and so it wasn't recognized when the initial testing came back negative for Ebola virus until they tested for this particular strain. And so because of that, the outbreak has been, I think, brewing for a little while, probably several weeks and maybe even a month or two. And so we're now sort of playing a little bit of catch up in that area. And cases have been sort of escalating. And so if you've been following the news about Ebola, it was initially there was 40 cases. And the new numbers out yesterday from the WHO and the CDC that we're over 900 cases now with over 200 deaths. And so that's a pretty rapid escalation over the past several weeks. And if you talk to or listen to anyone that sort of is involved in the outbreak response, it's clear that they all think this is going to get worse probably before it gets better.
I mean, I assume one of the reasons that it is going to get worse is because it went undetected for a longer period of time than we wanted it to.
Correct. Absolutely.
And how is this disease spread?
Yeah, so Ebola is spread mainly through infected bodily fluids. And so you have to have really close contact with someone for Ebola to be spread. So I think that's the first point that people need to be aware of. I think, us who are a little older remember the 2014 to 2016 large outbreak that was in Western Africa. That was a different strain of the virus, the Zaire Ebola virus. And that was primarily affected three countries, Guinea, Sierra Leone, and Liberia. And there was, by the time that outbreak ended, there was close to 30,000 cases and over close to, I think, around 11,000 deaths. And so very large numbers, very high case fatality rate, about 40%. But again, this only is spread through close contact through bodily fluids. And so it's not spread through respiratory spread at all. And so you can sit on a bus or a plane next to someone who has Ebola, and you're not going to get infected with Ebola. And the other really, really important thing about thinking about Ebola and spread of Ebola is that unlike other things that we think about, there's no pre-symptomatic spread. And so until you actually have symptoms, so fever, you are not capable of spreading the Ebola virus. And that's really important in terms of thinking about how this spreads, how we protect people, how we quarantine people, and those sort of things.
The mortality rate is really concerning, but what you said about, having to be symptomatic in order to spread the illness And also that it's not through the air is reassuring. So why do so many people have it in Africa
Currently in
right now?
Africa?
Yeah.
Yeah, so that's a great question. And I think it has to do with some cultural issues within Africa, as well as some infrastructure issues that are happening right now in that part of the world. So, first of all, as I mentioned, you have to have close contact with someone who's sick. There isn't a really good health infrastructure currently in the DRC. Where this is happening, it's really in an area of armed conflict that's been going on for a while. It's also in an area that has a lot of gold mines, and so there's a lot of a migratory population there, and there's a lot of displaced people because of the armed conflict. So there's this interesting mix of people there, people that are moving a lot, and so things can be transported as people travel around that area. But then because there's not a really good health infrastructure, a lot of people are being taken care of in their households, and so it can spread within households and people get sick. The other way that it spreads very commonly, this was a big problem in the outbreak in 2014, is that what people do with their burial and funeral practices in this part of the world, it's very customary for people to sort of be laid out after they die and for families to come touch the bodies. And actually, right after you die from Ebola, there's really high levels of the virus in your body. And so touching any of the body or bodily fluids is a really very high risk activity. And so there's very clear documentation of large spreading events during funerals in this part of the world because of those practices. And that's probably another reason why it's spread so quickly. So as more people die and there's more funerals, then more people are being exposed if we're not aware this is what the cause of the death was in these communities.
Let's talk a little bit about the virus itself. What does it do? How long is the incubation period? How does it present clinically?
Yeah, so Ebola has an incubation of anywhere from 2 to 21 days. And so if someone is exposed, that's the time that they're sort of on watch to make sure they don't develop symptoms. And clinically, it has two different phases. So we talk about a wet phase and a dry phase. And so the initial phase is the dry phase, and that sort of presents, unfortunately, like lots of other things. And so it presents with fever, myalgia, is not feeling very well. And so it can look like influenza, actually. It can look like malaria, which is very common in parts of Africa. And so the differential is actually very broad in the initial phases of someone presenting with Ebola. And so that actually also complicates the matter, too, in terms of diagnosis, in terms of recognizing that someone could have Ebola, because Ebola overall is a relatively rare disease. So initially it presents, like I said, this dry phase. And people actually aren't as contagious or infectious during the dry phase because they're not making a lot of bodily fluids to expose people. But as the dry phase moves into the wet phase, and the wet phase really is the more concerning phase, and that really is when people develop pretty severe vomiting and diarrhea, and then in the late stages they develop bleeding complications. And the vomiting and diarrhea, I think we didn't fully really appreciate that part of Ebola until the outbreak in 2014. Think about cholera. So think about really, really, really terrible vomiting and diarrhea, the fact that you're having huge volume losses and need to be replaced. And that's a big problem because all that vomit, all that diarrhea, those are infectious materials. And if that's just what's sort of pouring out of the person who's sick, the healthcare workers or other people are the ones that are going to get exposed and infected. I read this really interesting article and a really wonderful description that Ebola really is a disease of compassion, meaning that the people who get sick from Ebola are the people that are caring for people who are sick with Ebola. So family members really are at high risk, and then healthcare workers actually are at very high risk for exposure to and contaminating and getting infected with Ebola.
How does one treat Ebola?
So that's a great question. It's primarily symptomatic care. The good news is because of what happened in 2014, that there was an acceleration of thinking about preventative measures as well as therapeutics for Ebola. And there was actually 2 vaccines that were developed against Ebola, but against the Zaire strain. And unfortunately, that's not going to work against the current strain that's circulating in the DRC. So that's actually one of the problems with the current outbreaks, that we don't have a vaccine. In other outbreaks, we've now been able to do what's called ring vaccination. So when there is known to be a small outbreak, we can quickly sort of vaccinate people that have been exposed and then get bigger and bigger circles to protect people that could have been exposed to the virus. We can't do that in the current outbreak because we don't have a vaccine that works. And then there were some monoclonal antibodies that were developed against the the Zaire strain. Again, those probably will not work against the current strain that's circulating. And there were some sort of experimental other sort of small molecule drugs that were developed. Again, probably won't work in the current strain. And so really, we don't have any known therapeutics that will work against a particular strain that's circulating in this outbreak, and no vaccine. So it's really only good supportive care. And sometimes that requires ICU level care for people that get very sick with Ebola. The I guess maybe silver lining of this current outbreak is that this particular strain seems to have a smaller or lower mortality rate than the Zaire strain, which is probably the most virulent strain. Estimates, anywhere in the 50 to 70% case fatality rate. And then the Sudan would be the next sort of more severe strain. And then this would be the third. People say in other outbreaks, there's only probably been 2 other documented outbreaks, and the case fatality rate was in the 25 to 40% range. So that's maybe the one silver line. Still very high, but not as high as some of the other strains of Ebola virus.
And are people dying from dehydration?
Yes, they can die of dehydration, dying of electrolyte abnormalities, and then you can also die of bleeding complications as well.
And how do the bleeding complications occur? Does the virus actually affect the liver, clotting factors, or how does that work?
Yeah, so the virus is really, from a viral standpoint, pretty great in terms of what it can do. So I talk about there's sort of 3 things that the virus does. First of all, it's really good at suppressing your immune system and causing immune dysregulation. And so it has different proteins that it makes that sort of attack your immune system and can sort of cause overall systemic immune dysregulation. So that's a problem when you're trying to fight off anything. The other thing is that it has pretty broad tissue tropism. And so it can attack multiple organs all at the same time. So your liver, your kidneys, your spleen, all the things that we sort of need to sort of help fight off infections and to keep us alive. And it can cause direct sort of cytotoxic effects. So kill those cells and cause direct damage that way, and cause endothelial damage as well. So the bleeding complications can result from that as well. And then it also can cause this sort of paradoxical, even though it's causing this immune dysregulation, and causes paradoxical huge inflammatory cascade, which results in what we call a cytokine storm. And so can present like the sepsis-like syndrome as well because of this huge cytokine storm. And so the virus is really great in terms of how it attacks us in terms of making us sick, because it has all these different layers that it can use all at the same time to sort of attack us and make us really sick.
How do we think this started with patient 0?
Yeah, we don't know that yet, but people are sort of trying to do the backtrack epidemiological links. But we do know that Ebola viruses, their natural reservoir are fruit bats. And so the other way you can get exposed is sort of from an environmental exposure, an animal exposure. There is also spillover events from bats into primates. And so either from an exposure to primates or to bats is probably where the first spillover event occurred. And that could happen from eating the meat or from an exposure. Sometimes people have been exposed to bats in a caving incident. It's been reported for other Ebola viruses, or Marburg virus, is a similar virus in that same family. But commonly can happen through also butchering of primates or bats as well.
Let's take a step back and talk about the public health lens of the current situation. So, you've said some things that are reassuring to me. People have to be symptomatic. It has to be body fluids. But how do we contain what's been going on? And you said 900 cases so far.
Yeah, so this is really principal public health intervention. So we really need to have very, very strong public health presence. So I think the first thing we really need to do for any sort of Ebola outbreak is you need really good rapid case identification. And so that's because you have to know who's infected, and then you need to watch those people in case they become sick. And so once you can do good rapid case identification, you really need to isolate people who are sick and care for those who are sick. And so you need to have healthcare providers that can care for people who are sick with Ebola. So we need, like we had before, we need to, have really good Ebola treatment units or ETUs that WHO has set up before, Dr. Border set up before. Other sort of humanitarian healthcare organizations really need to be on the ground caring for these patients. And then there also needs to be really good contact tracing. So we need to be able to follow people and their exposures. That again that's a huge lift for public health. It takes a lot of resources, but that's the only really way to contain the spread is to have really good contact tracing. And then the other thing that really needs to happen, we sort of alluded to this already, is that we need to talk about safe burials. So how do we culturally sensitively approach that issue, that we can honor sort of the culture that is there and provide for them in a way that is acceptable to the people in those cultures, but also do it in a safe way so we're not having other spreading events. And then the other thing that people talk about from a public health standpoint is really having strong community engagement. And so one of the big issues with Ebola too is that it induces, rightfully so, a tremendous amount of fear. And so this has happened before, and unfortunately it's already happened again here, is that when people come in to help, they often are met with a lot of resistance. And so just the other day, one of the ETUs, the Ebola treatment unit, was burned down by people that were afraid. They were, this is the vision that I sort of try and tell people. Imagine you live in an area of the world that has never sort of seen people use any sort of PPE, and you come and there are these people in these spacesuits that come into your area where you live, and you have this tent, and your loved ones go into the tent and they don't come out because they're dying, right? Because half the people are going to die of Ebola. And so just picture yourself in that situation and what amount of fear that might incite, and you're trying to sort of tell people that you should bring your people here to get cared for, but what you're seeing happen is very emotional, right, and devastating. And so I think there needs to be really good communication, good cultural, anthropological engagement with communities to sort of confront sort of how do we work on this together. So all that, as I said, requires a lot of resources. And this is a part of the world that has very poor resources in terms of their infrastructure, of their healthcare system. And so that's a big problem. The other big problem is that the WHO's budget has been shortened this year, probably because of the US withdrawal. And so there's not as much money to help sort of care for this part of the world. And USAID, which was a big factor in the other Ebola outbreaks in terms of caring for patients, getting things sort of logistically up and running, has been canceled, and so that is also not available for utilization and mobilizing resources to help fight this outbreak. And so I think that's a big issue in terms of the resources that are currently available in the DRC, both locally but also from a global standpoint as well.
I think from a pediatrician point of view, should I be screening in my office? I have some patients from the DRC.
Yeah. So those are all great questions. First of all, I want to say that the U.S. has started doing port of entry screening. So I think that's really important. That's been very effective in other outbreaks. Screening, I think, is a really good tool from a public health standpoint. And so I think they just changed it, I think, yesterday, that the U.S. now is screening and sort of routing all passengers from the DRC. And I think also Uganda to 3 ports of entry. So Atlanta, D.C., and I think Houston and Texas, where they'll be screened and monitored. So I think that's actually a really good thing. So that's one thing that the U.S. is doing that I think is helpful in terms of protecting the general public. The other thing I want to point out is that here in the United States, the risk to us is right now very, very low. So let's just look back a decade to the previous outbreak that was huge, a huge outbreak of 30,000 people in West Africa. We had a total of 10 cases during that time frame here in the United States. 8 of those were not acquired here in the United States. Only 2 of those were acquired here in the United States. And those were those 2 nurses who took care of the patient in Texas, if you remember that story. But I want to actually reflect back on that story. I think that's a really important story. There was a man from the DRC who came here to Texas, and he actually got sick while he was in Texas and was living in an apartment building. And while he was sick, went to the ER, I think once or twice actually before they recognized that he might have Ebola. And so was in the ER. No one in the ER got sick from Ebola. No one in his family got sick from Ebola, even though he was symptomatic. And it was only when he was in the later stage of disease during that sort of wet phase that I talked about earlier, that 2 nurses who were taking care of him got infected with Ebola. And so even though, it theoretically possible someone could get into our country who had Ebola, still the risk of transmitting is very low. And that just is a tale of just showing that, you can be living in the same household as someone who's sick with Ebola, and your risk of getting infected is low, particularly during the dry phase. It really doesn't escalate till you're in the wet phase where the risk of infection goes up.
Yeah, we have the World Cup coming to the U.S. this summer, and I'm pretty sure the DRC has a team. And so a lot of people on social media are talking about, what's going to happen with all the people that come, not only the team, but they're going to have fans and family and all those types of things. But it sounds like there's a system in place, 3 ports of entry in the U.S. And I suppose it's possible to get through that without knowing, given an incubation period. Should I be in my primary care medical home? Should I be screening there as well right now, or is it not yet at that level?
Yeah, no, we here at Children's, we screen people. We do travel screen. I think travel screen actually is important for anytime you're seeing a patient to understand what their risks are for disease they could have caught somewhere else. I think even I'm much more about measles right now, and we should be screening about that. Have you been to a state or an area where there's an outbreak of measles ongoing, like Utah, previously with South Carolina or Texas? I think that's really important information when you're seeing someone to understand what they could have been exposed to. So yes, if you have a patient who presents with a febrile illness, it's totally reasonable to ask if you traveled anywhere in the past 21 days. And if they've been to the DRC, then that should be a red flag. And they have a febrile illness, then you should, call the public health department and sort of see if this is a high risk situation or not. Those patients, however, should be already being followed by the public health department. So they should, when they come into this country, if they've been recently in the DRC, the CDC is contacting state health departments to let them be aware to follow these patients while they're in that 21-day incubation period.
So if you were me in a primary care medical home and you have families who are coming in and nervous about this because of all the news out there, what would be some talking points you would use with those families? Yeah,
first of all, I would say that the risk to any American currently is extremely low. First of all, there's no known cases here in the United States. And so from that standpoint, the risk is very low. Second of all, the fact that we're screening all people who are coming into this country from those parts of the country, from that part of the world, makes that risk even lower. So again, the risk is very, very low. The third point, even if someone were to get into this country, they need to be symptomatic in order for them to transmit the disease. And really, you have to be exposed to their body fluids while they're symptomatic. So even just a fever, you sitting next to me on the bus with a fever is not going to be a risk factor for me to contact Ebola. So overall, I know it's a very scary disease, but the risk of transmission currently in the United States is extremely low.
Given the low risk, we kind of batted back and forth whether or not to do this episode. I do want to call out that because it's been so present in the media, we thought it would be important, especially because, your friends, family, neighbor, patients are going to ask you questions about it. And we thought it would be good for you to be armed with some facts from our experts here at Children's Hospital Colorado.
I want to point out in terms of thinking about Ebola and its impact on the world in general, WHO Director General during the outbreak in Liberia and Sierra Leone in 2014, she issued a statement which I thought was really wonderful. People were asking her, why is this outbreak going on for so long? Why is it so severe? And she said that initially one of the biggest concerns was that why it spread so quickly and was hard to control was because of poverty in that part of the world. And that's an important issue for all of us, no matter where you stand. And then she said, 6 months into the outbreak, the biggest issue was fear. And that's a big issue too. We have to understand what's going on so that having knowledge actually is important to help combat that fear. And then the other really great quote that I found that I think is really important for us to think about, from our point of privilege, but also from our concerns that are happening in our own country here in the United States. This is a quote from the head of Doctors Without Borders during an outbreak in 2018, 2019 in the DRC, where they were experiencing a lot of resistance, and there was another attack on one of the ETUs during that outbreak as well. And he made this statement: Ebola is worsening despite medical progress because trust is breaking down. Medical innovations need social traction to deliver results. Paradoxically, the strength of the response only feeds the perception that we care about Africans only when they get diseases that can harm us, not when they are dying of diseases we can treat easily and cheaply. The mistrust of authority in the DRC also reflects a growing global mistrust of experts in science. Vaccine refusals are a growing problem worldwide. Mistrust of public health authorities may thus be the new norm, and smoldering epidemics merely a symptom. I think this was a statement that came out in 2019 before the COVID pandemic, and I think it was really sort of predictive of some of the challenges that we faced during the COVID pandemic, highlighting some of the issues that we all are facing, no matter where you live and what community you are part of, that we need to think about in terms of how we approach public health, how we approach vaccines, how we approach science in general as we move forward.
Yeah, I mean, speaking of the COVID pandemic, it sort of stirred the pot, so to speak, in terms of it really brought to fruition people's thoughts, feelings about infectious diseases, vaccines, et cetera, et cetera. And I've been experiencing that in primary care since. Do you think this sort of extra focus on, people are more tapped into infectious diseases and how they can affect our daily lives, is that a good thing, a bad thing, both? What do you think?
Yeah, probably a little both.
Yeah.
I think it's a good thing in terms of understanding what's happening in our communities, locally, nationally, globally. I think that's important to know. I think that really knowledge is power. It's really important to know things that are happening so you can protect yourself and be aware of what's happening. I also think that the bad part of that is I don't think this is call for hysteria. Like, we have to have a good understanding of what's going on. What are the real risks as opposed to perceived risks? And how do we, work together to sort of keep everyone healthy and safe? I think that some of the biggest problems that we're facing in the world are infectious in nature. And I also think in terms of what causes pathogens to emerge is a whole nother podcast we could do about pathogen emergence, but those things aren't going away. They're actually also probably increasing, the reasons why pathogens emerge. And so understanding those factors, understanding those issues, I think are important as we try to combat that from a societal level.
Yeah, I think a lot of what we do in medicine boils down to two words, and that is to ease suffering.
Absolutely.
And if people have fear, then they are suffering. And to alleviate that fear can be a part of our healing power.
Yeah, that's really good.
Sam, thank you so much for coming on the podcast again. And thanks for all you do. And thanks for being here.
Yeah, great. Thank you.